I'll start with the first case. So this is a 25-year-old female who had sudden onset of weakness in the right upper limb, followed by paraparesis, and gradually progressed over a 3 weeks period. Also had some sensory disturbances, vibration hypoesthesia, indicating involvement of posterior columns, right? Also had bladder bowel involvement without any visual symptoms. Okay, guys, so this is T2 sagittal image. So what we see here is a long segment of signal alteration involving the cervical cord. There is mild expansion also. And superiorly, if you see, there is involvement of the cervicomedullary junction, right? And inferiorly, it's extending till the single, right? The important point you notice here is that you can see is there is a thin rim of cord parenchyma that appears to be spared, right? That is clear? Okay. So again, in this image, this is T2 Sag again. So what we see here is there is a small cystic area. And on axial, you can see this cystic area and the signal intensity of this cystic area that resembles that of the CSF. So it is a bright, small cystic area within this lesion, right? So again, this is T2. Here we have T1 sagittal and this is T1 post contrast, right? So what you see here is on T1, the lesion appears to be mildly hypointense, and on post contrast, there is only a patchy area of contrast, cloud-like contrast enhancement, and this enhancing area corresponds to this area on T2, right? So SACD longitudinal transverse malaria. Okay, so guys, see at this point of time, we'll have to keep differences like neoplastic theology. It is absolutely difficult. Just having seen these images, it's difficult to rule out a neoplastic etiology. Okay, someone has written aside wrong. But again, this is a young female, so you must keep some other differences in mind. So okay, we'll look at some other images as well. We'll have to look at other soft pointers that can help us in differentiating tumors versus this other pathology that I'm talking about. Okay. Okay, now in the same case, if you see, so this was the lesion that we're talking about. And now you can see here, this part of the cord is spared, right? And inferiorly, again, you see there is involvement of the cord, okay? And at this level, this axial section shows that there is a central T2 hyperintensity with sparing of the peripheral cord parenchyma, right? So this, in between the cord parenchyma is spared. So now this is something that tells us that maybe we are not dealing with a neoplastic etiology, right? Because again, we have this normal cord parenchyma in between, and the inferiorly the cord again appears to be involved, and with mainly the central pattern of involvement. Okay, guys, any other differential? The young female, a longitudinally extensive lesion, and we are seeing a relatively normal cord parenchyma in between. NMO, perfect, oxidized paper. Very good. So this is actually a case of neuromyelitis optica. Okay. So brain imaging was also done in this patient. So what we see here is this is T2 and here we have flare. So what you see here is there is T2 and flare hyperintense signal intensity along the ventricular lining, right? So this is what this is occipital horn of the lateral ventricle. And what we see here is there is T2 flare hyperintensity along the ependymal lining of the occipital horn of the right lateral ventricle, right? So this is DWI, and here we have GRE, and what you see is nothing significant on DWI and nothing significant on GRE, right? Okay. And on post contrast, what we see here is there are small foci of contrast enhancement along the in this area, primarily along the ependymal surface of the occipital horn of the right lateral ventricle. So now, with more confidence, we can say that we are not dealing with a neoplastic etiology because we have intracranial lesions as well. We have cord lesions, in cord. What we saw, there is involvement of the cervicomedullary junction. There is thin rim of peripherally spared cord parenchyma that we discussed, right? And we also had a skip lesion. So all these findings are pointing towards demyelinating etiology, and therefore we kept the possibility of NMO, longitudinally extensive lesion, right? Okay, so in this case, the optic nerves they were normal. And what is this? This is flare sagittal image. So this this is midline sag. Okay, so this section is very important when you are dealing with the case of a demyelination, right? Why? Because so this is corpus callosum, and here somewhere here is the sorry somewhere here is the septum pellucidum, and so this is the callosocaptal interface. So what do you see in pathology? You see lesions in the callosocaptal interface, multiple sclerosis. So in MS, you will see lesions here, right? Good, Priyanka. And then in NMO also, what we see the aquaporin 4 receptors. Where are they present? They are present along the ependymal yama, but presence in NMO, right? So the aquaporin 4 receptors, they are lined, they are present along the ventricular lining. So in NMO also, you can see lesions along these, because these are all what? Ventricular lining, ependymal lining, you can see lesions along these areas, right? So this is periaqueductal, and this is somewhere hypothalamic area. So all these areas are involved in NMO. And again, along the fourth ventricular lining. So this area you have to evaluate whenever you are dealing with a case of demyelination, right? So in this case, forced differential was neuromyelitis optica, as I've already discussed. What the reason behind that? Age, young, female, the pattern of cord involvement. So cervical cord involvement, a longitudinally extensive lesion. Then I discussed bright spotted sign, peripheral sparing of the cord parenchyma, right? The enhancement pattern, cloud-like enhancement pattern. Then also in this case, there was dorsal cord involvement with normal segment of cord parenchyma in between, then also intracranial involvement. So all these findings point towards demyelinating, and this case was neuromyelitis optica. Okay, so another differential of granulomatous sarcoid, maybe it has different pattern of involvement. We'll see subsequently in later. We'll see a case of sarcoid as well. And we have discussed reason why it was not astrocytoma, right? So this actually came out to be positive for neuromyelitis optica, right? Okay, now let's have a look at another case. So this is a 42-year-old female, okay, presented with multiple episodes of vomiting and then weakness. Okay, so this history was again short, sagittal limit, and this is T2 axial limit. So what is here is patchy area of T2 hyperintensity. So where the lesion is located, so again, this is at the cervicomedulla. So this is what? This is medulla, correct? And this is from here the cord starts. So this is again at the cervicomedullary junction. What is this? This is this bulge. What is this? This is clavum, okay? And this clavum basically it comprises nucleus gracilis and nucleus cuneatus. So from here the cord starts, and this is the area of involvement that is mainly centered at the cervicomedullary junction, patch area of T2 hyperintensity. Again, if you see here, uh, again the this part of the cord is spared, and then small bright T2 hyperintense area in this case as well, right? And on contrast, so this is again T2, this is T1 post contrast. What you see again, ill-defined cloud-like enhancement, correct? So uh, at this point of time, again, as because we have discussed the similar finding in the previous case, possibility of again in this young middle-aged female, the involvement of cervicomedullary junction. Again, you have to keep a differential of demyelination as well as astrocytoma. Can you rule out astrocytoma in this case? We have seen soft pointers like sparing the petal cord parenchyma, and again a bright spot in this case, bright cystic area in this case, and ill-defined area of enhancement again. So we are favoring a demyelinating pathology, but if we find other lesions like this rest of the cord or intracranial or optic nerve, yeah, central lesion in this case as well. So if we find other lesions, then we'll be sure that we are dealing with a demyelinating case, right? So in this case, again, at lower level, this was at C4, C5 level, can again see a small centrally located lesion surrounding the central canal of the spinal cord, okay? So with this finding, we will show that we are dealing with a demyelinating pathology, okay? Again, a lesion in the cervicomedullary junction with certain type of enhancement, and again, another lesion in the lower part of the cervical cord. Okay, so this also was a case of NMO, right?